Holders with the plus framework. I might repeat a few things.
Sorry about that.
Thank you. Thank you. So again, what you see on the right side, Kroger being out of the network and what that impact is to your constituents. So 20 to 25% market share, about 800,000 scripts that are now going to other pharmacies. That obviously impacts members from a disruption standpoint. Kroger was dropped from the current PBM's network, costing over $100 million. So, far out of line, and shifting those prescriptions to already overworked pharmacies is a challenge. So, this is something that a company like Capital RX can help remedy. You already have Kroger in network. Moving on to the next slide here, NADAC. So getting back to NADAC and the advantages of this financial framework, the other advantage is that it's deflating. So when you look at in particular, generic drugs, which are typically the most utilized drug, it is a significant deflation compared to the blue line, which is what is indicative of AWP, average wholesale price. So average wholesale price continues to go up by about 1%. It doesn't sound like a whole lot, but when you compare that to the index of NADAC, the cost plus, it is night and day. And what you see here, the orange line and the blue line, depending on how the contract is set up, gives PBMs that leverage spread pricing the ability to potentially keep everything in between. So this is one of the advantages of NADAC, and it's continuing to deflate. If you talk to anybody that's responsible for purchasing drugs, they will tell you that the cost of those drugs is going lower. Now, the challenge of RFPs specifically. So in this example, and I want to be very clear, this is not based upon PEIA data. This is what we see typically across industry RFPs. So in this particular example, the consultant ran an RFP. The projection showed 17% savings in this example. Yet the actuary will, they will state plus 5% for proper budget projections. Stop loss attachment point is 9%, but when you get to the end of the contract or the end of the year and you do that analysis and reconciliation, the costs are up 8% versus a 17% projected savings based upon an initial RFP. We see this all of the time with traditional PBM deals, and we actually pulled the actuarial documents that are publicly available for PEIA. Costs continue to go up. And so a big issue and the reason, one of the reasons for this, is that RFPs really focus on unit costs, not total net costs. How are you managing a plan properly to shrink the total balloon? Unit costs are really just looking at rebates, discounts, but it doesn't always play out that will be the best deal. And so when you look at where savings actually come from an aligned pharmacy benefit manager, the first two areas here, that's really what most of the RFPs focus on. It's very difficult, or has been historically difficult, for consultants and RFPs to capture the true value, what that means, and looking at that total net cost. But the first two areas are really only about 30% of the total value. What we see across our book of business and our clients that we're working with and managing, certainly want to have the most aggressive discounts and rebates possible, but it's also making the right clinical decisions to ensure that members are taking the right drug and not just pushing high-cost drugs out the door because a vendor may be incentivized to keep a portion of the rebate or whatever it is. As we talked about before, the misaligned incentives that exist. However, there is a way to capture total net cost in an RFP. And as I touched on in the beginning, it can be done through an all-in PMPM guarantee, guaranteeing a net cost. What are you spending today for your pharmacy benefits on a PMPM, per member per month basis? And that is what we would guarantee tomorrow. So looking at it as one number and simplifying the process, but through this process and putting fees at risk, guaranteeing the management to one number, this drives the ultimate level of predictability. And you now have the ability to wrap all of those areas of value that I showed on the last slide into this approach. It's much easier and simpler to do, and it can be done. And I'm encouraged by other state RFPs that are being run today. Connecticut, for example, is one of those where they're sourcing all-in PMPM offers and making PBMs put their fees at risk, putting their money where their mouth is and holding them accountable through that process. So it can be done. The market is shifting, and it's shifted quite a bit even since the last time PEIA. So these next two slides are similar. I'm just going to jump 2 slides ahead here, and kind of touched on this already, but it's drug mix. It's having an aligned partner who is making the right decisions for the plan. Not every patient or member necessarily needs to take that high cost medication. It's ensuring that it is the right drug at the right time, and again, driving to lowest net cost. What is most necessary in that moment. So, when you think about an RFP, when you look at the numbers on the front end, in this example here, if we were going up against a legacy PBM, we may not show the strongest rebate number, but when you look at how the plans are managed and decisions are made, looking at the prior authorization approval rate, for example, 90% is actually on the low end. Most vendors that exist are in mid-90s in terms of prior authorization approval rates, meaning drugs are just going out the door. We are sitting at about a mid-60, and that has a lot of financial impact on the plan. And that's how you get to a lower total net cost. So looking at the total costs, net of rebates, you can see it has a significant effect on the total result. So one more slide here. So the access to data is an extremely important part of running a proper procurement and analysis. What you see on the left side, this is a list of the typical data elements that we would request, and we will generally get for savings analysis. But what you see on the right, what was actually provided by PEA, is not really close to anywhere that we would typically get on a typical analysis. So it's hard for us to really identify proper savings. So on the right side, what transaction level data shows us, this is from with help from a local consultant, from an actual self-funded commercial employer where we were able to obtain all of the data elements that you see on the left. This individual cancer patient, I'm not even going to try to pronounce this drug name, but it was filled 6 times by the specialty facility. The plan was charged just over $890 per prescription. The patient paid $250 per prescription. Plan was charged in total just over $5,300, of which the patient paid $1,500. When you compare that to NADAC, the NADAC price plus a $10.49 dispensing fee cost was about $70, just over $70. Meaning the plan should have been charged about $422, and the patient should have paid $85 for all 6 prescriptions. This is a real life example. Again, this is not from PEIA data, but we can safely assume that you would see similar examples if we had all of the data from the PEIA plan. So with that, our recommendations for the committee: demand the appropriate data to do a proper evaluation of the pharmacy benefits plan. Again, the latest poll of the publicly available actuarial reports are that the costs are going up, and conduct a full RFP that focuses on net costs, total net cost guarantees, holding PBMs accountable, because you can do that, demanding no spread pricing, demanding that they do not own dispensing assets, and making them bid on an all-in PMPM basis. Ideally, moving to a NADAC framework as well. Hopefully this was helpful, and we'll end my presentation. You can see if there's any questions from the committee.
Are there any questions for our presenters? We do have a few minutes here before we have to move on to the next presentation. Senator Moran.
Thank you, first of all, for the presentation.
Sure.
I think it's important that we're finally getting serious about some of these talks. I think we left a lot of money on the table. We want to put the stake in. The members of PEI and recipients of PEI is one of the pockets of some of the PBMs. And I appreciate you being here and doing that. Sure. I want to talk again. I got a couple of questions and I'll put whatever one to do that. The first one is Kroger. Okay. Talk about Kroger not being the network. There's a reason they're not the network, right? They left the network voluntarily, correct?
I believe it was a contractual issue. Yeah.
Okay. It's because it's my understanding it's because the almost 1 million prescriptions, 800,000 prescriptions is decided to walk away from. Why would you leave 800,000 prescriptions on the table if you're a business in the state? And the reason was because every time someone walks into the Kroger, get a prescription, PEIA, if they bought nothing else, Kroger lost one day. Kroger was subsidizing the healthcare, the PEI system, because they were losing money on these prescriptions. And that's why they left. Is that a fair assessment to your knowledge?
Yeah, I believe there was, contractual disagreements. I think if they had the ability to basically claim, the fair price that they expect on a dispensing fee basis, that could change things. So, and that's why the NADAC plus a dispense fee approach makes sense, and kind of back to the, allowing the free market to work itself.
When was the last time that the PEIA PBM contract was up for grabs?
I believe it was a year and a half ago. It was the last RFP.
Was your company involved in bidding for that process?
We were, yes.
What did you think of that process?
The RFP unfortunately was structured to mainly focus on AWP basis, and it was not set up in the way to really focus on a total net cost basis and different innovative models.
Okay, so yeah, I'm not trying to get you.
No.
Here, maybe I or anything, but just, so it's almost like it wasn't fair. I mean, is that what you're saying? Or it wasn't. So they did PEI and RFP, obtain a new PBM, but it wasn't set up in order for them to get the best bang for the buck.
Correct. Yeah, the way that the RFP was structured at the time was really focused on the legacy model. And unfortunately, we see this time and time again in the marketplace. But that's one of the reasons why we're here today and having this discussion, because a lot has changed even since a year and a half ago when that RFP was run. And I believe the consultant that ran that initial RFP is now open to doing.
Do you think PEI need help setting up the parameters of their RFPs? I mean, we're going to put the code how I expect to run an RFP so they get the best deal for the PEIA participants and also the best deal for the state. Is that why wouldn't they do that on their own?
Yeah, I think the market historically has always leaned on leveraging consultants to help run the RFPs. I would strongly suggest that if we can obtain a new and complete data set, that we also provide suggested terms and questions if an RFP is reopened, and that PEI should demand and put into that RFP process.
Agreed. The last question. I don't know. I can't remember what slide it was. It was early on. It was about these prescriptions filled state by state. What your company was to have a contract, how would you be able to help with increased number of prescriptions that are filled in state pharmacies?
Yeah, absolutely. So we partner with a ton of health systems. I would say that's probably our fastest growing vertical in large part because they own their own dispensing assets. And a lot of them want to drive 100% utilization to the dispensing assets that they own to keep within their ecosystems. So it's the same approach here. We do not own a mail or specialty pharmacy. We're not going to mandate that those are filled outside of West Virginia or at a certain location. Essentially, we are here to administrate the plan, and PEIA tells us how they want to fill those scripts. So leveraging other local pharmacies ideally to keep those prescriptions and total cost within the state.
That would explain why 42% was a
Yes.
huge number from one to Indiana. Is there being steered that way by the current PBM?
Correct. Yeah, our assumption is that the existing incumbent vendor's specialty pharmacy facility is in Indiana. So that explains why all of those scripts are going there, because it's an exclusive arrangement that mandates the filling of those drugs there.
Thank you. That was very helpful. Appreciate it.
Sure. Thanks for the questions.
Any other questions for Presenter? Delegate Summers.
Hi, thank you, Mr. Duffy, for being here. I will say that you present why so many of us have a negative connotation about PBMs. And it's really kind of refreshing to see that there can be the same way to have the same model with a different results. We passed the NADEC plus $10.49 for Medicaid a few years ago because, like you said, dispensing fees, is free market. That's wonderful. It's really exciting. I think it also showing the example of the cancer drug is why people have such a negative feeling towards pharmaceutical companies and PBMs because of all the money that's made instead of taking care of the patients that need it. My question for you is, if a patient, you said you do cost savings by having higher prior or not as many prior auths. So if a patient is on a drug that is a brand name that works for them and they don't want to change to a generic, does your company make them change to it?
No, I mean, ultimately,
Or is it up to the doc?
well, typically, it could depend on a number of factors, right? Plan design, how the plan wants to manage the benefit. However, a PBM that is aligned, and if they're held accountable to managing to a certain number, they will look to ensure that does it even make sense to start that high cost drug. Far too often in the industry, because of so much misalignment, that high cost drug that you see on television, patients will go into their physicians and ask to be put on one of those high cost medications. A lot of times, if the PBMs are potentially keeping a portion of the high rebate that is associated with that high cost drug, they have no incentive to check to make sure that that is clinically necessary in that moment. However, there may be a lower cost alternative, a generic drug that is far, far cheaper and doesn't come with any rebate. That would be smart to start with. So it's making those decisions and having the right type of oversight in place to ensure. Now, if the patient needs that drug, they're going to get the drug, right? So I don't want you to think that a lower prior authorization approval rate comes with massive disruption. It doesn't. When done right and managed well, it works, and it works very effectively, and it saves the plan money.
Okay, thank you. No, I just wanted to clarify that. Okay.
Yeah, absolutely. Thank you.
Any other questions? Senator Tarr.
Thank you, Mr. Chairman. When's the last time you asked for the data set to provide an RFP?
Say, I believe a few months ago. I have to get back to you on the exact date. Yeah,
So what was the response from them when you requested?
it was just decline. That
You say
they were unable to provide all aspects of it.
Did they provide any
Just what you saw there on the previous slide.
this last time that you asked?
Yes.
Okay, so and then in order to get the RFP in, how much time are you given to prepare in order to get an RFP?
How long does it usually take to?
My concern is that Western Union has had a history, and this is my opinion, of protecting incumbents within these contracts with the state. And so making the RFP process a little less transparent than it should be.
Mhm.
Also hamstringing anybody who might be a newcomer by giving a very short time process. So I'm curious how much time you had, in spite of not being able to get the same data that I'm certain the incumbent has because they have all this, they're providing all the scripts.
Yep.
How much time are you given to prepare relative to them being there as they are as an incumbent? Sure. Having the ability to prepare all along.
Yeah, I mean, just to give you a general sense of the timeline for an RFP for a plan of this size for PEIA, for example, I would expect 4 weeks, 5 weeks, maybe more, depending on the questions and financial requests. And then, implementing a new plan, should they choose to move vendors, at least 90 to 120 days as well. So I understand, I think that.
Maybe I should reframe it. Do you have sufficient time to prepare the RFP under the current regulation we have? So if you're wanting to bid for this, do you have time to prepare well for it and implement it given the timelines that are now established?
Based on a 7/1 effective date that is maintained, there should be enough time if we were able to obtain the right data elements.
So the main shortfall is just getting the rest of that.
Getting the data and then understanding the rules and components of an RFP.
Have you been told why you can't get that data?
Contractual obligations.
They signed a
No
contract, they
clear
wouldn't
answer.
provide the data for anybody else who would provide the RFP.
I don't think so.
Not that proposal.
Tell your talk.
Mr. Chairman, thank you for being here. How does your PBM define a specialty drug? Because from previous testimony we've heard in this committee from others, there is no set definition. So how does your company define specialty drug?
How do we define a specialty drug? Well, that's the problem with the industry is no clear definition. It typically follows a price. So I believe the industry needs a clear definition. It doesn't exist today.
So it makes it very difficult to compare apples to apples when PEIA is looking at PBM plans on what is covered, what is not, what's in, what is out, and what it really costs. Would that be a correct analysis?
Yeah, I think so.
Now, I have a question also about your specialty prior authorization approval rate in the process. So your approval rate is 67%. For others, it's 90%. What is the process for providers or patients to appeal a denial? How lengthy is the process? What is the satisfaction rate for the providers that have to access it? So if I'm a provider, I've written a particular type of prescription for a patient because it meets their needs.
Yeah.
And you deny it. How many steps are there in that process to get maybe the drug approved for a patient?
Yeah, I should have included, we have a very good detailed slide that I can provide after today's session. But our prior authorization process tends to be 3 to 4 days on average. In the industry, it's 7 to 10. It's usually very cumbersome, and oftentimes the patients are left waiting and confused by the process. Typically, maybe 3% actually hit a PA, 3% of prescriptions and numbers will hit a PA. From that, it's very, very few that would go to a first or a second appeal. But that's usually the process. So if for whatever reason that initial PA is declined, it would go to a first appeal and then potentially a second appeal. But the general PA process is relatively about half industry average.
And is that an electronic process for providers to be able to access that system, or what is the actual physical process to do that?
It is, well, it depends. There's a number of layers, but typically it would be lettered conversations with providers.
So if it was a letter, we could say that sometimes mail doesn't come through for weeks, maybe a week or 2 weeks to get a letter. So I think that might be a little bit more problematic if it's not an electronic process. That would just be an option.
There is, well, so the standard PA process, it's absolutely electronic. It's still, electronic fax essentially, but that's still what everybody tends to use. So for that process, and that's one of the reasons why our initial process is about half the time of the industry average. And more importantly, we have actual clinicians and pharmacists engaged to manage that process. So that helps streamline it.
I have some information. I'd like you to seek out some data for us, maybe from PEIA. We were talking about pharmacy coverage. And can we get a breakdown based on county of the PEIA members, which pharmacies in each county fill the highest number of prescriptions? It doesn't matter if Kroger's is in my network, I don't know if Kroger's in my county or my patients can't get to that particular pharmacy. So I'd like to know that. And maybe I think some of the other community members might want to know that as well.
Okay.
The top 3 pharmacies that fill for each county.
Okay, we can have the staff look into that. Real quickly, Senator Martin and I do have one question.
Okay, then a 30-second follow-up, because I think myself and Senator Tarver would kind of on the same path. Maybe I'm going to make a statement, you can tell me if it's accurate or not, because it's my understanding. So it used to always be, well, it's my opinion that we've been spending as a state way too much money. And we've got money on the table that the state would have, and also PEIA to have a better plan all around, not just the pharmacy benefits. And still more money for the state, if in fact we, this PBM thing under control earlier. Now's the time, we haven't done it yet, but with the, well, they used to always be this information proprietary, so, no, everyone else was, could break in because they couldn't get the information to make the RFP or do whatever. It always is proprietary. It's really, no, I don't believe it is proprietary. And PEIA owns that.
Yeah.
That's their data, not the insurance company's data, or not PBM's data. They may have written in a contract, which will, who knows why they would have done this, that with that company, that this is our data, we won't share it. But that to me seems to be the biggest hurdle. And why we would let that continue to exist, I have no idea. Is all that accurate?
It is, unfortunately. Yeah, I mean, and that's why we wanted to show that example of data that you were able to obtain for that cancer patient and assume that you would see similar trends within the PEI data, because that is from a self-funded commercial employer in West Virginia, and it's relatively easy to obtain those data elements in a relatively quick fashion. So we would fully expect the same for a plan the size of PEI.
Well, Mr. Chairman, I'm not asking my questions, but I'd love to, at some point in time, have a chance to talk to PEI and direct PEI, find out why we can't give information to companies bidding to offer our state citizens better plans.
Yeah, we can put that on for the December meeting. Okay. The last one, one of the things that I think you've heard pretty consistently is this committee is, I think, the opinion that our pharmacy costs have gotten out of control, and our recipients, we've got to bend those cost curve back in. So if I look at this one slide, I mean, and I know you're not putting out an RFP, but is it your opinion that there's about 22% savings to be had under a model like this compared to the PBM model that we're using currently?
That is an example slide of what we see. We run and respond to about 500 plus RFPs per year and across groups of all sizes, 1,000 employees up to 500,000. So that could be the potential for PEIA, but we won't know until we actually see the data and respond to that and run the analytics. Potentially. But that was not based on actual PEI.
I think that wraps up this presentation, but I would hope that you'd be willing to stay afterwards if some members have any questions.
Absolutely.
I know I do. Okay. With that being said, we thank you for your time in this presentation, your willingness to answer questions.
Thank you.
And your willingness to stay a little bit afterwards. With that being said, I'd like to move on to our second presenter, Jeff Knight, who is President and CEO of the Health Plan, to come and update us a bit on what the Health Plan does. I would like to, on behalf of the committee, I would like to thank Wheeling for their hospitality and the Health Plan in particular for the hospitality and hosting us today. We've all come to already get that Wheeling feeling. So with that being said, if you could come to the podium and he's getting your slides located. Oh, there they are. Okay. Mr. Knocker, please state your name and position for the millions listening on the internet, and the podium is yours.
So my name is Jeff Knight. I'm the president and CEO here at the Health Plan. First, I want to thank everybody for coming to Wheeling and coming to the Health Plan. We're really proud to show our building off to the committee and to the state, quite frankly. I know you guys are running behind on time, so I'm going to make this really quick. I want to talk a little bit about the history of the Health Plan for those who may not know who we are. The Health Plan started back in 1979 because of this act, the HMO Act of 1973. It supported over 200 companies with grant and seed money. The Health Plan received $1.8 million Most of those 2,000 companies actually failed, went out of business. The remaining companies were acquired by larger insurance companies, and the health plan is still here today, which is it's a really nice story to tell. And we were one of the only plans to actually pay back the 1.8 million that we received from the government. Real quick, we are a 501c4 nonprofit organization headquartered here in Wheeling, West Virginia since 1979. That $1.8 million has turned into $300 million in reserves today, which is very impressive. We have over 570 employees. 400 of those employees reside here in Wheeling. 100 are in Charleston, and then we have the remaining 70 employees scattered throughout the United States and also in Ohio. We serve all 55 counties in West Virginia, 75 counties in Ohio for our fully insured business. And we have great relationships with the providers here in state and also outside of the region as well. We use national relationships to help service clients that aren't locally in this area. This is a little history of the health plan. One little piece of information I would like to share here. Since 1982, we have been an option for PEIA. I know PEIA is one of the discussions for this group, and we'll talk about a little bit more about that here in a second. This building was opened in 2018. It was an empty lot, and one of the things that they discovered when they were clearing the property were vaults that were used during the Prohibition era. And it's a really neat story to tell, and we wanted to preserve that history. So when you're walking out today, you will see that the concrete blocks that were part of the vaults are actually out in our landscaping out front. We have a lot of fully insured products. This slide just basically demonstrates that we do a lot of things for a lot of different companies. We try to make sure that we're controlling healthcare costs, and that's why we do so many different things, and we're willing to do as much as possible for our employers and our members. We are also a third-party administrator. One of our key accounts is Zappos Shoes out in Las Vegas. All the third-party administration that we do is, well, we do that in 50 different states, but all the revenue comes back here to West Virginia. Those employees are hired here in West Virginia because we can do it more cost-effective than some of our competitors across the country. And as I mentioned about PEIA, we've been doing it since 1982. We are an option. The other option is the self-insured PEI plan, which you guys are talking about. We have 14,000 PEI members today. Most of those members reside in the Northern Panhandle. I'll say about a third of the population is in the Northern Panhandle. The health plan assumes all the risk. So PEI pays us a premium. We either do well or we lose money. We never go back and get money back from PEIA. There's no risk sharing, no cost sharing associated with our relationship. That was really quick. Sorry about that, but I'm willing to take any questions anybody has.
Well, I'm going to start off with a question.
Sure.
I'll dovetail off our last presentation. Which PBM do you use?
We use Express Scripts.
Do you bid it out every so often?
We do.
How often?
Every 5 years.
5.
We do a market check every 2 years to make sure that the rates that we have are in line with the market.
And does that market check have bearings on the contract that's in place at the time?
It does. So there's basically some guardrails, and if they're outside those guardrails, then we're able to get those newer rates implemented in our contract.
And that's a contractual obligation of the PBM to enter into that 5-year contract.
Yes, it is.
Any other questions for you? Senator Tarr.
Thank you, sure. Commissioner Knight, does Express Scripts, do they keep proprietary of the utilization of scripts when they're providing bids? So when you go out and you're going to get a quote from the PBMs, I know if I go to get an insurance quote in the private market, unless I'm or self-insured rather, chances are I'm not going to be able to get to see that utilization data from whoever's providing our employee insurance, which is very frustrating when you go out to market to get bids. As the health plan, when you go to PBMs, are they confidential with that data to themselves, and they're keeping that data themselves like they are from the state?
It's proprietary.
You can't see it either. So you suffer the same frustration.
We do.
Have you had anybody that used the cost plus measure like NADAC, as we saw before here, bid for the health plan?
So I am not familiar with that.
Yeah, Senator Brown.
Thank you, John, very much. Thanks for moving to West Virginia 7 years, or 6 years ago, whatever it was, because you guys were in Ohio for all that time. Your commitment to West Virginia
Glad to be back.
is appreciated. Appreciated, very much so. Here's what the last thing you said, I wasn't aware of. I was aware you had a product, PEIA, but just to go into this a little bit of detail. So, because I'm trying to figure out why it wouldn't be a bigger hit PEIA than something that you said, yeah, I don't think I'll figure further panel. Because you said they pay up front. There's no fallback trying to get extra money if they overutilize or things like that. How's that product working? Is the premiums of that product compatible with the others?
So the PEI premiums are obviously significantly lower than a traditional employer group on the street plan that we also offer.
What about your PEIA premium? What about your PEIA premiums? Where they're all in to begin with, you don't have to go back and get any money from anybody versus other PEIA premiums.
So I'm not sure what you're asking there.
Okay. Well, it sounds like a good product to me.
It is.
The way you described it. And I'm just trying to figure out why not as many people are using that product.
Okay, so the self-insured plan is able to set the rates, and those employee rates are set by PEIA. So our rates will different than the PEIA rates. That's done by their actuaries. We have no control over those rates.
Okay, thank you.
One other thing I would like to say so this plan, it's open to other managed care organizations if they want to participate in PEIA. Throughout the years, we were paying at rates that were much higher than the PEI self-insured plan up until this past legislative session when the law changed as to what the premiums were for the facilities and also providers. So it leveled the playing field for us and the self-insured plan. And hopefully that entices more carriers to, jump into PEI.
Any other questions?
I just want to know why you had Nixon in his, I'm not a crook.
That was somebody else uses
Great
that.
offense to that.
Someone else uses that slide and I hijacked it.
No further questions.
Taking it yours, but-
No further questions being seen. Is there any other business to come before the committee at this time? Any business being seen, the co-chair wants to co-chair the purpose of the motion.
Mr. Chairman, I move be adjourned.
As moving on to the adjourn, all those in favor, signify by saying aye. Those opposed? The ayes have it. I declare the meeting adjourned.
Yes.